Now go on to our next speaker, Dr. SHAIL VASAVADA, who again needs no introduction, who's a consultant cataract and refractive surgery from Raghudeep Eye Hospital, and has had innumerable awards and accolades at a very, very young age. And I'm sure we're going to look forward to seeing another very impressive video. On to you, Dr. SHAIL.
Thank you very much, ma'am. In all of the cases shown previously, sometimes you start up with everything going on perfectly, but it doesn't end up well. So this was a posterior polar, long-standing posterior polar, and we prefer doing the femto delineation in this, where we like to divide it. It's like multiple hydrodelineation, except for the fact that you don't require any fluid to be injected. And we try and remove each epinuclear layer from the support of the other. And when the final epinucleus is being removed, we don't completely remove it. We just create a communication so that now some fluid will trickle in, and that will make sure that the intralenticular pressure doesn't rise. I think bimanual irrigation aspiration is of utmost importance in such situations, and never allow the chamber to collapse. And we thought we have done an excellent job. There's no dehiscence that has been created, and all is well that ends well. The next cases started to be prepared. But notice here that as soon as I'm trying to inject, I generally do a wound assisted through 2.2. I'm being a little bit more casual here. The eyeball is already rotating on the other side, and I'm not using my left hand enough to pull it back. And that made this the angulation of the engagement in the wound a little bit different. So it sort of lifted up rather than staying down. And so I'm struggling to actually inject it through it, and eventually it snapped. Now, any posterior polar, however much you have been careful, this capsule is very fragile, and that was my main worry, that this slight snap may have actually created something in the posterior capsule. So I didn't want to take any sort of chance. So first injecting dispersive viscoelastic, and then I didn't want to manipulate or push or pull too much on this IOL, because I thought doing that may cause more harm. So I just extended the incision a little bit more, and while trying to actually manipulate it, then I realized this huge defect that has already been created. So now I'm in a little bit of a fix. Almost the entire IOL, except for the trailing haptic single piece, is now inside the anterior chamber. I have an intact anterior capsular axis, but I have this large posterior capsular dehiscence which I've created due to these maneuvers. So first thing is not to panic. I again go below the IOL and inject dispersive viscoelastic, and I thought, let me try and convert these margins of this tear into a strong margin. So from one end, I've been able to convert it, going below the IOL. But I could feel that since I've enlarged the incision, there may be prolapse of the vitreous that may come due to this large chamber. So first I sutured the wound. And I created a pars plana entry so that whatever vitreous that will be there, I will need to tackle it from there. So from the other side, going again below the IOL, I've been first now able to convert this into a strong posterior capsular axis margin. Then injecting triamcinolone, obviously there was vitreous that was coming out through there. So with pars plana, what I'm trying to do is I'm trying to sever the connection from the posterior to the anterior segment, which you'll notice here very shortly. That once the vitreous is cleared and the connection is severed, you will start seeing this nick of vitreous now floating. So once you see that start floating here, that means that the connection from the posterior part is removed. And then that means you can remove this from the front part, because now it's not going to keep coming. The vitreous is not going to keep coming back. So finally, I've sort of converted this into a strong vexus margin and have managed to remove the vitreous. I want to make sure that I see everything that I'm going to be doing, because this is a single piece IOL. So I want to be extremely sure that when I dial this lens in, not only do I not put much stress, but also make sure that the optic haptic junction goes inside the capsular bag. Initially, I thought it did go, but then on retracting the iris, I realized it's still not there. So it's very important to keep seeing and making sure that the optic haptic junction in this case is absolutely inside the bag, because you cannot leave a haptic of a single piece in the sulcus. So once again, making sure that the anterior capsular axis is covering all around the optic. Once that is done, we once again make sure that during this manipulation, there was no form of any vitreous further disturbance that was created. And this little strand that was stuck in the incision comes out because there is no, connection now with the posterior segment. So this is, the end result of the surgery, where fortunately the single piece has been able to be put inside the capsular bag. Always make sure that even in the end, you do not let the chamber shallow, and hydrate all the incisions before you leave out the irrigation cannula. And this is the patient doing quite well post-operatively. So every step is equally important in posterior polar. It's never over until it's over in a polar, and even the slightest error, even while just injecting the IOL, can lead to a disaster. It's always a good idea to convert your tear into a capsulorhexis. Even if you do not place IOL in the bag, it's always a good practice to start doing to try and convert it into a PCCC. And I think in such situations, definitely pars plana form of vitrectomy helps, so that there is no further prolapse of the vitreous that keeps coming up. Thank you so much for the patient listening.
Thank you very much, SHAIL. That was a wonderful, wonderful video. And actually, incidentally, I had seen your earlier video. I had not seen this video which you had sent day before. But there was nothing more to what he could have done. The way he has done, kept even the haptic outside, he sutured it so that there is no Irish AC shallowing, and how he has done a PCC, and how he did the pars plana vitrectomy so that there was no gush of vitreous coming forward to enlarge the area. But supposing it was a little in the subincisional area, even though it was nearly there and you did manage to make a PCC, but with the haptic IOL mostly inside, and if you were not able to convert it into a PCC, in that kind of a theoretical situation, Swapna, can you tell me how this could have been handled?
In this particular situation, I thought initially there was no vitreous because you could see the margins of the tear curled up well. It was not stretched out like it would be when there's vitreous prolapse into the pupillary area or the chamber. So I thought because 3/4 of the IOL was inside, more than that rather, maybe a gentle maneuvering into the remaining space where the with the haptics, well away from the area of dehiscence, I should have kept the IOL there. Then when you aspirate, it should have been minimal aspiration, with low dynamics and all that. So that could have settled, I guess, the entire situation. I mean, he knows best because he was in it.
That could have been risky.
Yeah. Yes.
That could have been a risky because it's a one-piece IOL, and extension of that PCR would have been a possibility. The only option I could thought is remove that lens and place a 3-piece IOL with the optic capsule.
If you put viscoat in the region of the PCR, it keeps the vitreous away enough for you to, manipulate a lens which is already inside the anterior chamber and tug it into the fornices, the haptics.
Yes,
that was only the question of dialing that last haptic,
the inside.
Pulling haptic inside, yes.
Yes.
Just one thing I was thinking, the trigger of all this was the smaller wound, right?
Yes.
So that brings us to the question that this is one of the fallouts of the 2.2. So what I was trying to think is, if this can happen in this case, so even in a routine case, I've seen many times a wound assistant, the wound is not really very good and nice at the end when you're trying to actually push the injector through it. So do you all actually feel that in all these cases, it is better to go in with a 2.2, or it's best to have a clean 2.4 or a 2.6 or 2.8, which would probably reduce the astigmatism and reduce such complications?
Yes.
I absolutely agree with Anaga in the sense that, years together we are doing 2.2. Now we are, as a standard, we are shifted over to 2.4. So less of distortion of the wound, and it's much more easier. And especially in a posterior polar cataract situation, sometimes, this push type injectors have a more explosive release. And if you have a screw type, it might be a more controlled release that might happen. But anyway, SHAIL, good that you showed this video. I always thought you never have complications. You created one like a novice, but managed it like an expert. I think
Can I give my bit here?
my
Yes,
comment
yes.
is the sense that I think it was halfway stuck there. So instead of pushing this lens, I have also landed in these situations, and I often tend to bring the lens out rather than trying to stress the capsule and then reload the lens and maybe slightly enlarge the incision and then doing it in a more controlled manner. That works out, especially in a PPC where you know that the capsule is likely to be a little friable and easy to give. Trying to maneuver it in is not a good idea. And again, making the incision larger with the knife, with the lens stuck there, and your knife that you introduced was cutting on both sides, and I could see it leaving a mark on the lens also. So I would not have done that with the lens stuck there, and maybe I would have tried to maneuver the lens out of the back, out of the incision, enlarge the incision slightly, reloaded it, and put the lens back. But
And
once you were in the mess, you came out like a master.
yeah, and you should also inject viscoelastic to the side port before pulling out that lens, because there could be some kind of a AC shallowing when you're pulling it out. Supposing the scenario was even more difficult, like there was epinucleus also sitting in the bag, and when we have had a PCR, so how would you, it's only epinucleus, would you look at doing a visco dissection at this point of time with an open PC? Dr. Vavikar, your thought? That's a theoretical situation, because SHAIL's video did not leave too much for discussion. So I'm asking.
Yes, excellent video. I would definitely think of visco dissection, but before that, I will clear off any vitreous is there in the bag or anterior chamber. And in a PCCC, in a posterior polar cataract, it is not all that easy to convert to complete a posterior capsular rhexis, because the cut is oblong rather than a punched out lesion. But if there is no vitreous, then visco dissection is definitely one of the easiest maneuvers to do. Safest, not easiest.
Would you want to do a femto, on those of you who are on the femto platform, any PPC you see, would you strongly advise a femto laser procedure only, or you just put it across to the patient and leave it at that? Dr. Swapna?
Yeah, I mean, we were doing PPCs before femto was around. The femto definitely helps.
Yeah.
But yeah, I would tell them that could be safer with a femto, but maybe not always insist on it.
Yeah.
It would depend on the grade of the cataract, actually. If it's a harder cataract, I would insist on it. If it's a softer cataract, I wouldn't insist on the PPC going in for a femto.
Dr. Ramurthy, would you comment on doing a reverse optic capture in these, not in that particular case, in a case of small PCR in a PPC?
Yeah, I mean, in case like he managed to do it, you have a very strong, nice posterior capsular rhexis and adequate anterior vitrectomy has been done. There is enough support. You can place the lens in the bag itself. But otherwise, the possibility if there is not enough support, then you can have the haptics inside, and through the side port using a something like an iris spatula, you can gently maneuver the optics out of the bag. The haptics stay inside and the optics get caught in the rhexis margin. I think one of the major advantages of using a femto, apart from the nucleus delineation, is that you have a perfect well-sized rhexis. And as we know in this PPC, we aim at a 4.8, 4.9. So when you end up in a situation like this, whether it is reverse optic capture or conventional optic capture, you are able to do it much more easily.
We shall now go